You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for September 5th, 2025. This week, some brief listener feedback, the big beta blocker story from ESC, dual pathway therapy with aspirin and anticoagulation, stopping anticoagulation after successful ablation, and DANCAVAS II. As there were so many big trials from ESC, this podcast is a little longer than normal, and I'll get back to my normal 20 to 25 minutes soon. First, listener feedback. I received 2 emails regarding my coverage of the recent Western Danish study of patients with CAC0, coronary calcium 0, and high LDL. Recall that study looked at relative risk of events in patients with coronary artery calcium of 0 and varying levels of the LDL. Compared to those with normal LDL cholesterol, the comparator arm, people with higher levels of LDL had higher rates of disease, and there was a gradient of risk higher among younger people. And the take-home message was that CAC0 was not so reassuring for patients with higher levels of LDL cholesterol. Now, the first objection I received came from an American cardiologist who made 2 points, and one was that while the relative risk were increased, the absolute risk was minimal. He wrote, quote, "The long-term prognosis for this patient is excellent, and there is no indication to change management, i.e. add a statin." And then he added this zinger, which really hit me. He wrote, quote, "Almost as bad as missing the details in the statistics, your title, CAC0 takes a gut punch, is a sensationalist and misleading lead." Okay, I take your criticism. The second note, listener feedback, came from a Portuguese cardiologist who noted that while there is still a lot of education to do about the use of the test, there is another area where coronary calcium may help, and that is as a gauge of the aggressiveness of the lipid-lowering therapy, if even it's needed. He suggested forgetting the classical question of, should I start a statin, and start to ask, what's the target LDL level for this particular patient? He cited a very useful example of a 50-year-old male that had a coronary calcium score. If the score was 0, he wrote, I'd be fine with an LDL of 95 to 100. However, if that same patient had a CAC score of 350, and therefore a risk of MACE similar to someone who had already had an MI, I'd be much happier to get his LDL to less than 55. Both of these commenters are correct, and their pushback reminds me of my mentor, Dr. Bill Miles, who reminded me more than once that a test is never bad or good. What is bad or good is the doctor's use of that test. The fact that I regularly see patients misled and utterly mismanaged with coronary calcium scans in my community should not bias my assessment of the proper use of coronary calcium scans, which is solely for risk stratification. But please, my friends, please do help me spread the word amongst patients and doctors alike that coronary artery calcium scans should never initiate a search for ischemia in asymptomatic people. All right, next topic is the big beta blocker story from ESC. 2 large pragmatic trials testing post-MI use of beta blockers were presented at ESC. Now, I say pragmatic because both the Spanish reboot and Northern European beta-MI DAN block trials randomized patients to beta blocker versus no beta blocker in patients who had an MI and left ventricular ejection fraction greater than 40%. The choice of beta blocker was left to the doctors, and there was no placebo tablet. Now, perhaps you have heard that the 2 trials had conflicting results, which is technically true, but I will make the case that the overall message is clear, and that the strong guideline recommendation of routine use of beta blocker after MI should be stopped. The reboot trial was a Spanish trial, 4,200 patients, average age 61, LVEF 57%. The most common beta blocker used was bisoprolol. After 3.7 years, a primary event of death, MI, or hospitalization for heart failure occurred at a rate of 22.5 per 1,000 patient years in the beta blocker arm versus 21.7 per 1,000 patient years in the no beta blocker arm. The hazard ratio was 1.04 and clearly not statistically significant. There were also no significant differences in any of the components of the composite endpoints, and Reboot definitely showed no signal of benefit. The Beitammi-Danblok trial was a merged Norwegian and Danish RCT where 5,500 patients were randomized. The most common beta blocker here was metoprolol, the mean age 63 years, 21% female, and about 16%, so less than 1 in 5 patients, had an EF that was mildly reduced at 40 to 49%. After 3.5 years, a primary outcome event of death or major adverse cardiac event, which included a lot of things, including MI, unplanned coronary revascularization, ischemic stroke, heart failure, or malignant ventricular arrhythmia, occurred in 14.2% of the beta blocker arm versus 16.3% in the no beta blocker arm. The 2.1% absolute risk reduction translated to a statistically significant 15% relative risk reduction, hazard ratio 0.85, confidence interval 0.75 to 0.98, p-value 0.03. The driver of the composite endpoint was a 1.7% absolute risk reduction in reinfarction. That hazard ratio was 0.73 and also statistically significant. All other components of the primary endpoint, including death, were very similar in the two groups. Beitammi-Danblok was a positive trial, albeit with a small effect size in a non-fatal outcome. All right, another part of the story was a meta-analysis that was also simultaneously published, and the authors of the two trials, along with the authors of the capital RCT, which was a smaller RCT of only 800 patients post-MI from Japan, combined data, and they did a meta-analysis of all the patients in the trials with an EF of 40 to 49%. Now, each of the three trials had a small fraction of patients with mildly reduced EF. The total combined in the meta-analysis was nearly 1,900 patients. Now, the authors of this meta-analysis chose as their primary endpoint death, MI, or heart failure. And before I tell you the results, remember that each of the Reboot and Beitammi-Danblok trials had about 4,000 to 5,000, and here we're talking of a sample size of less than 2,000. All right, the results of the meta-analysis, which was published in The Lancet, in the beta blocker arm, the rate of the primary outcome was 32.6 per 1,000 patient years versus 43 per 1,000 patient years in the no beta blocker arm. The relative risk reduction was a statistically significant 25%, hazard ratio 0.75, and those confidence intervals went from 0.58 to 0.97, and the p-value, again, close to the threshold at 0.03. Now, all the trials were directionally consistent, but none alone were statistically significant. Each component of the primary outcome was lower in the beta blocker arm, but none of those reached statistical significance. Now, I want to make a contrast to show you how small the difference was. The difference was about 19 fewer patients, 106 versus 125, who had an event in the beta blocker group versus the control. Now, that's 19 out of 1,900 patients randomized. There was another study simultaneously published, and this was the Reboot authors published very helpful observational post-hoc study from their main trial. Euro Intervention was the journal. It turns out that about 12% of the patients who were on beta blocker before the Reboot trial were then randomized to no beta blocker. So essentially, these patients were withdrawn from beta blocker after their MI. This group was older and had more comorbidities, as you'd expect, because they were on beta blockers. Yet there were no differences in this subgroup, and importantly, in patients taking beta blockers before their MI, randomization to no beta blocker withdrawal was not associated with an increase in ischemic events. Now, the fifth study we need to consider when merging all of this post-MI beta blocker data is the reduced AMI trial. The reduced AMI trial was published in 2024. This trial randomized about 5,000 patients with normal EF, totally normal EF, post-MI to beta blocker or no beta blocker, and found no differences in death or MI. So my comments, if you sum all of these studies, there are about 15,000 patients randomized to beta blocker or no beta blocker. in the setting of modern contemporary therapy of MI, including revascularization. The next step in thinking would be to combine these trials with our prior beliefs, right? Prior beliefs plus data equals the posterior beliefs. How much did the data change or reinforce our prior beliefs? Trials never provide answers. They just update our prior knowledge, just like medical tests do. So the first question is, what should have been our prior beliefs about beta blocker after MI? Should we believe what the quality measures and guidelines suggest, namely that beta blockers are so crucial to give post-MI that if you fail to do so, then you are not a good quality doctor and your hospital is financially penalized? In the U.S., for instance, administrators grade the quality of hospitals and doctors based on how often beta blockers are used after an MI. This would make you think that the results of these trials are surprising. But let me propose a different prior belief, namely that we really have no strong evidence of beta blocker after MI. Well, why would I say that? Because the seminal trials of beta blockers in the 1980s vintage BHAT and ISIS-1 trials randomized patients way before primary PCI came of age and stopped much of the injury that used to occur with MIs. But perhaps even more relevant than the revascularization issue was that the trial procedures in BHAT and ISIS-1 would be completely foreign to us now. In BHAT, for instance, propranolol was started very late after, quote, stabilization of the patient on hospital day 9. Hospital day 9. We don't keep patients in the hospital after MI for 9 days. In ISIS-1, the benefit in vascular death was about 1%, and it was seen in day 1 after IV atenolol, and was not seen in the subgroup of males or those with softer blood pressure and higher heart rates. My belief before these trials, therefore, was that the beta blockers in the modern era were unlikely to add much to an already good prognosis post-PCI for MI. Now, with that belief, it is very little surprise that 3 of the 4 trials returned null results, and that in the one with positive results, BETAMI-DAN block, there was only a 2% absolute risk reduction in a non-fatal outcome. I will bet you all at cappuccino that when the trials are meta-analyzed together, the 3 negative trials will negate the tiny signal in the BETAMI-DAN block trial. Now, as for the meta-analysis and the idea that we should keep giving beta blockers for mildly reduced LVEF, I see 4 reasons to be skeptical. First, the absolute difference in outcomes in the meta-analysis were tiny. Only a handful fewer patients had a primary outcome in the 1,900 patients. The difference in both death and MI were less than 0.5%. Second, the difference barely met statistical significance, so it may even be noise. Third, I do not believe that cardiologists can easily discern subtle differences in EF. For instance, I really doubt that someone can see a difference between 51% don't use beta blockers and 44% do use beta blockers. What's more, if you do an echo in 2 months, a 40% EF could easily be 51 to 55%. And fourth reason for being skeptical about the meta-analysis is that the prior evidence that beta blocker benefits these patients is weak. Please do recall that the seminal CAPRICORN trial of patients who had an MI and reduced LVEF, randomly assigned to carvedilol or placebo, actually had a non-significant primary outcome of all-cause death or cardiovascular hospitalizations. So my final summary of all this is the totality of evidence clearly supports reversal in practice. There may be reasons to use beta blockers in highly selected patients with MI, but the mandates and quality measures for routine use of post-MI beta blockers should end tomorrow. Now, I've heard some say it was not a big deal to know that beta blockers don't help. The drugs really don't hurt, so it doesn't really matter. I disagree with this thinking. The knowledge that a drug doesn't help and that we don't need to prescribe it means that we can simplify the drug regimen, which is a huge positive, right? Because after an MI, you want to remove any distractions so that patients take the meds most likely to reduce future MI, such as their antiplatelet drugs to keep the stents from thrombosing and statins. And of course, the meta lesson, the general lesson of these strong trials is that our established therapies require an expiration date. As practice changes, we should be open to challenging established beliefs, Few better examples exist in medicine than the post-MI beta blocker story. All right, next topic is even more important and perhaps more practice-changing, which is a lot. A French team presented a trial called the Aquatic trial. This was oral anticoagulation plus aspirin versus oral anticoagulation plus placebo in patients with two common conditions, and that is chronic coronary disease with a previous PCI and stent more than 6 months ago, and an oral anticoagulation most commonly for AFib. Now, consider this as a comparison of dual pathway treatment. That's antiplatelet and anticoagulant versus a single pathway or only anticoagulation alone. Aquatic may be the most definitive and most important trial of ESC, and you and I see patients on this combination often, perhaps every week. The idea makes sense too, right? You're on aspirin for secondary prevention for chronic CAD, and patients, of course, are on anticoagulation for their AFib. It's a simple thing. One drug covers one problem, the other drug covers the other problem. Both agents have a class 1 indication for their separate conditions. The problem is that patients are not machines where you can tweak one thing without affecting another. In humans, combinations matter. Now, I don't get the attraction to aspirin, but clearly it has this aura of safe and mild. Well, Aquatic should absolutely change our thinking about the combination. Every outcome was worse when anticoagulation was combined with aspirin versus placebo. The 872 patients enrolled in the trial had to have chronic CAD. They had to have a previous stent more than 6 months before enrolling in the trial. They also had to be receiving an oral anticoagulant for any reason, not just AFib, though AFib was the most common reason. Notably, these were quite high-risk CAD patients who had either stent for ACS more than 6 months ago or a PCI for stable disease, but with other high-risk conditions such as diabetes, diffuse multivessel disease, CKD, a previous stent thrombosis, peripheral artery disease, or a history of complex PCI. The mean age of patients was 72 years, 85% male, and nearly 3/4 had had a previous MI. All patients had a previous PCI, most more than 12 months before enrollment. The oral anticoagulation indication was AFib in 89%. The median CHAS-VAS score was high, 4. DOAC use was 90%. The primary efficacy outcome was a composite of CVD, CV death, MI, stroke, systemic embolism, coronary vascularization, or acute limb ischemia. The key safety outcome was major bleeding. And the results? The trial was stopped early for harm in the dual pathway arm after 2 years of follow-up. A primary efficacy outcome occurred in 16.9% in the aspirin group versus 12.1% in the placebo group. That hazard ratio was 1.53, with confidence intervals going from 1.07 to 2.18, and that p-value was 0.02. Death from any cause occurred in 13.4% versus 8.4% in the placebo arm. That was a 72% higher risk. Major bleeding, too, was way worse, 10.2% versus 3.4%, hazard ratio 3.3, with confidence intervals going from 1.9 to 6. Now, the obvious conclusion was that dual pathway therapy, DOAC plus aspirin or anticoagulation plus aspirin, was clearly worse than the anticoagulation alone. The authors noted that Aquatic enrolled quite high-risk patients, but even in these high-risk patients, who you'd think would benefit from being on both, was clearly worse. Now, these results were similar to other RCTs in this space. For instance, the Aspirin trial in Japan was also stopped early for harm from the combination therapy. Now, the problem with the Aspirin trial was that it used a lower dose of rivaroxaban due to the fact that it was in an Asian population, and it also had a different primary endpoint. There was a Korean trial called EPIC CAD. This was another trial comparing edoxaban alone plus edoxaban plus antiplatelet, and this also showed superiority for the single therapy. That hazard ratio was 0.44. Major bleeding in that trial was 4.7 versus 14.2%. Now, what about the comparison of risks in the trial? The incidence of the composite CVD, MI, stroke, systemic embolism endpoint was 11% in Aquatic. That's very high. It compares to 1.5% in the EPIC-CAD trial, 2% in Pareto-AFib, 0.9% in the AFIRE trial, and 1.4% in the OAC alone trial. Notable was that all the patients in aquatic had prior stent implant, and MI was present in 72% of patients. This versus about 35% in other trials. Now, one limitation noted by the authors is that aquatic studied aspirin. Perhaps there is a small chance that clopidogrel may have fared better, especially on the bleeding side. Now, I doubt it because P2Y12 inhibitors were used in previous trials, which also showed better results in the monotherapy arm. My thoughts are that this should be it for using aspirin and oral anticoagulation after that peristent period is over. Now, the Bayesian priors here were that this dual pathway therapy is worse, and now, in a seemingly well-conducted trial, in patients at high risk of atherosclerotic events who are most likely to benefit, there is a strong evidence that dual pathway therapy is clearly worse, 53% worse for the efficacy endpoint, and 3 times worse for bleeding. And of course, the more general lesson here is that this is exactly why evidence is so important in the practice of medicine. The use of this combination seems to make sense, as you'd think that 2 different drug classes are needed, but clearly not. And had these trials not been done, we would not know. All right, next topic is to stop or continue anticoagulation after successful AF ablation. One of the toughest questions in EP is when or if to stop oral anticoagulation after successful AF ablation. The guidelines say to continue anticoagulation based on the CHADS-VASc score, irrespective of the success of the ablation. The evidence for this recommendation is nil, none, nada. And it was always seemed weird to me because if you started oral anticoagulation for AFib, and then you ablate AFib, and AFib is gone, and all you did was PVI, you didn't do extensive LA ablation, then it would seem best to stop the anticoagulation because you no longer have the indication for the drug. The concerns about stopping anticoagulation stem from a time when it was near impossible to determine if AFib was actually gone after ablation, as the ablation can render symptomatic patients asymptomatic. The other issue in this calculus, which in my opinion has never been adequately advocated for, is that anticoagulation is not free of risk. Major bleeding and cost are not nothing. Now, with the publication of the Alone AF trial from investigators from South Korea, we have some evidence. Emphasis on some, as you will see. The key inclusion criteria for this trial was that patients had to have no AFib for 12 months after an ablation, and they had to have at least one risk factor for stroke. Another bonus for the external validity of this trial was that AF was assessed using only 2 24 to 72-hour Holter monitors. I say it's a bonus because this reflects real-world practice, and the results can be more easily applied to everyday patients. 840 patients were randomized to stay on their oral anticoagulation or come off. The primary outcome was the first occurrence of stroke, systemic embolism, or major bleeding after 2 years. The mean age of patients was 64 years, 75%, and the mean CHADS-VASc score was low, only 2.1. 2/3 of the patients had PAF. The results. At 2 years, the primary outcome occurred in one patient, 0.3%, in the discontinue anticoagulant group versus 8 patients in the continue anticoagulation group. The absolute difference was minus 1.9 percentage points, and the confidence intervals went from minus 3.5 to minus 0.3, and that p-value was significant at 0.02. As for stroke, the incidence was 0.3% in the discontinue group versus 0.8% in the continue arm. Major bleeding was 0 in the discontinue arm versus 5 in the continue arm. The authors did a good job of not over-concluding anything. They just restated their findings. Except for one paragraph I found in the discussion section, which I believe was likely added during peer review. Here, the authors write that when stopping anticoagulation after ablation, it is, quote, important to do regular rhythm monitoring. Here is a quoted statement. In this setting, continuous invasive monitoring remains the gold standard for post-ablation surveillance, although prolonged intermittent monitoring with ambulatory ECG devices is a practical alternative. Now, my feeling is this statement is not supported from their data. In fact, it's sort of the opposite. They did not do close monitoring. And this lenient monitoring is one of the study's strengths because it shows that even if you just do regular, everyday Holter monitors twice a year without costly loop recorders, you get very low stroke rates. The ILR, the implantable loop recorder, the so-called gold standard, will often pick up short duration AFib. And the problem with that is we don't know what to do with it. We know from NOAA and Artesia that it's probably not net benefit to use anticoagulation when there's 1 hour or 2 hours of AFib. I think the main limitation with this study was its power. There were only a mere 9 primary endpoints for efficacy and only 5 patients with bleeding. It's really, really hard to make practice recommendations on these numbers. I surely would not even attempt a subgroup analysis. And this is not the author's fault. They randomized more than 800 patients and got so few events. I take from this that post-ablation risk of stroke or bleeding is super low, especially when ablating patients with a mean CHA2DS2-VASc of only 2. Saying much more than that is kind of hard. Now, I almost wrote that these small numbers of events is not enough to change recommendations, but then I remembered that the recommendation to continue anticoagulation, irrespective of AFib documentation, is also based on no data. Okay, 2 more considerations in this space. The one group of patients not studied in this trial are those with extensive AFib ablation, which is becoming more common in the PFA era. It's more common because PFA is so easy, and it's tempting to create left atrial devastation. Only 3% of patients in this trial had ablation beyond PVI. So I feel very uncomfortable stopping anticoagulation in a patient who has had lots of left atrial ablation due to reducing left atrial contractility, even when they're in sinus rhythm, though this is not an evidence-based idea. Another factor not covered in this trial or editorial for the trial is the matter of self-monitoring with watches and smartphone ECGs, which nowadays many of my patients wear watches that alert them to AFib, which they may not even feel. So the negative predictive value of these devices, I think, is decent. In other words, when they say there's no AFib, they're pretty good. Therefore, a post-ablation patient who has no symptoms, no ECG findings, a structurally normal heart, who went from having lots of watch notifications and symptoms to none, it's a pretty good guess that they're likely not having AFib. Okay, final point. There is another similar trial called Ocean, which is a peculiar trial with a peculiar trial procedures, which is randomizing patients with a successful ablation to rivaroxaban 15 milligrams or aspirin. The primary endpoint is going to be enhanced to clinical stroke, systemic embolism, and covert stroke measured by MRI, which will give them more endpoints. The trial has finished recruiting and is in the follow-up phase. I worry that Ocean 2 will be underpowered due to low event rates. I also worry that using the less than typical rivaroxaban dose in the active arm and a known problem drug like aspirin in the control arm will make translation more difficult. All right, next topic and last topic today is DANCAVAS II Trial. At ESC, Professor Axel Didrikson from DANCAVAS I presented results of the second DANCAVAS trial of invitation to a novel and uber-efficient cardiac screening program in men aged 60 to 64. DANCAVAS I used the screening program in men aged 65 to 74. By the way, the DANCAVAS program only studies men because a pilot study showed that women have far too low event rates to sort signal from noise. Okay, first the background, then the uniqueness of the screening, then the results, and then some commentary. Background. My Twitter feed, maybe yours, is abuzz with technology bros who, for whatever reason, have made avoiding an MI their main goal in life. The idea is as old as time. If you find and treat CAD before it strikes, you can cheat death. But the idea of the tech bros and mainstream cardiology in the US is that if you do such things, such as a coronary calcium scan, and you find disease, it can be, quote, fixed with PCI or CABG. Nowhere in this thinking are the problems of overdiagnosis, overtreatment, or that every single PCI trial ever done finds no benefit to stenting, quote, blockages over and above medical therapy in patients with chronic CAD. But Denmark, where people heed the evidence, is the perfect place to check whether screening for disease could reduce death. And that is the idea of DANCAVAS. that heart disease is a leading killer of people, that it is treatable in its early phase, and that treatment may create a net benefit. Now, the DANCAVAS method of screening is one that you would not recognize in the United States. They do 5 patients per hour, Professor Diedrichson told me. Pause there. That's 11 minutes per patient. A patient comes in, usually after clinic hours, fills out some brief questions, then they do a quick CT scan of the chest to look for only 2 things: coronary artery calcium and aortic iliac dilatation. And while they're in the scanner, they get the ECG, and then right after, an ABI, and then a cholesterol and glucose level. No radiologist overreads the CT scan. If there was a substantial abnormality noted, say a coronary artery calcium or PAD, then the patient was offered an on-site consultation. Every patient then had the results of the screening go to the general doctor, and then they got general Danish healthcare. This is a pragmatic, simple, and fast trial, 11 minutes per patient. In the U.S., it's 11 minutes to meet the lady at the window who hands you massive amount of paperwork to do. Now, you might ask, where was the randomization? This is interesting. It's well before the screen. In Denmark, patients have a national email. The DANCAVAS team therefore randomized about 31,000 patients to a trial where 25,000 got no letter, and 6,000 got a letter inviting them to this 11-minute screening program. But invitation is not the same as attending screening. Slightly more than half, about 3,700 of the 6,000 attended screening who were invited. The primary outcome was mortality. Secondary outcome was major adverse cardiac events and major bleeding. Results. In the intention to screen group, the 6,000 patients who were invited, after a mean follow-up of 7 years, 9.3% in the intervention group died versus 9.9% in the control arm. That hazard ratio was 0.94, or a 6% relative risk reduction, but this did not make statistical significance because the 95% confidence intervals ranged from 0.86 to 1.03. Major adverse cardiac events were 10.2% versus 10.6% in the invited versus non-invited groups. The hazard ratio there was also 0.96 and not significant. Severe bleeding events, however, were more common in the screened group. This was 6.0% versus 5.1%. That hazard ratio was 1.18. Confidence interval was 1.05 to 1.32. The p-value was 0.007. Perhaps the most interesting result, similar to DANCAVAS I, was that coronary revascularization was not only not increased in the screening group, but numerically decreased. Imagine that in the U.S., where coronary artery calcium scans was part of the screening technique. Now, one other thing the authors did, Axel Diedrichson told me that they were interested in the effect of the screening program in those who have it. But you can't do what the Nordic colonoscopy trial authors did. You can't just compare screened to non-screened, because those that don't attend are different than those who do attend. So in DANCAVAS II, they did a supplemental simulated model. And here's how I understand it. It's a little bit complicated. So they know the number of events in the intervention group, including the attendees and non-attendees, and they also know the number of events in the entire control group. They then make 2 assumptions about the control arm. They assume that the percent participation would be the same and that the event rate in the non-attendees would be the same. They then estimate the event rate in the simulated control arm who got screened by simple subtraction, and it yields an odds ratio of 0.83, or a 17% reduction that was statistically significant. Now, the authors acknowledge that this is an exploratory-only analysis based on big assumptions. I worry about it too, because when they report MACE, there are more events, more power, and the reduction is only 8% and not statistically significant. So the authors overall concluded, it's in the European Heart Journal, is that, quote, invitation to a comprehensive CT-based screening for subclinical cardiovascular disease did not decrease death over 7 years among men aged 60 to 64, but it did increase severe bleeding. They also add the sentence, because the trial was powered for events over 10 years, further follow-up is needed. So my comments, this is a great effort. I like everything about this project. I like the simplicity of the screen, 11 minutes. I like the primary endpoint, alive or dead. I like the randomization at the level of invitation. Is it worth inviting people to be screened or not? I love the humility of the conclusions and discussion. My conclusion would be that this highly efficient screening program in Denmark is the best case scenario, and it was non-significant. They saw no rise in coronary revascularization. Why? Because the lucrative and non-beneficial search for ischemia has not infected the Danish healthcare system as it has in the US, where coronary artery calcium scanners are like cash machines. A similar program in the US would be marred by A, regulation. Radiologists would have to overread the CT scans, leading to even larger pulmonary nodule clinics, and B, huge amounts of excess testing and PCI and CABG in the screened arm would lead to likely harm. So, in the end, in this best case scenario, there was no significant reduction in death or MACE, and there was a large increase in major bleeding, likely due to increased antiplatelet use in the screened arm. So it's just like Wilson and Younger famously wrote in the 1960s. They wrote, in theory, screening is an admirable method of combating disease, but in practice, there are snags. The DANCAVAS II authors are correct in pointing out that the low power where the hazard ratio for death could range from as low as a 14% drop in mortality to a 3% increase. 14% better to 3% increase. That equates to either a massive win in public health or a definite do not do. So there is a bit of absence of evidence of benefit is not the same as definite evidence of no benefit in this case. The authors say DANCAVAS is powered for 10 years, so more events may lead to tighter confidence intervals and a greater confidence in the point estimate. And they point out that better adherence to evidence-based medicine may lead to less use of primary prevention aspirin, and that would lead to less major bleeding. We shall see the 10-year results. And of course, finally, the meta or general lesson here is that this is exactly how we should test our well-intentioned efforts, with randomization and humble conclusions. And I say congratulations to the DANCAVAS team. And so that's it for this week in cardiology. I went a little long, and so I'm sorry for that, but there's so many good things to talk about at ESC and so much critical appraisal to do. I'll eventually get back to the shorter 20 to 25 minute format. Okay, remember, if you like this podcast, please take the time to write us a review or give us a rating. These things help others find us. In the meantime, if you disagree with something I say, please let me know. I'm learning a lot from listener feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.